for coming, everybody, and I appreciate you guys taking time out of your afternoon to come and talk to me about your knees. I'm thrilled there's people here with knee pain. So when I was asked to give this talk about kind of how to heal your knees, really the talk should have been called this. My knees are killing me and there's no way I'm going under the knife. And that's what I'm going to kind of gear the talk to right now. And hopefully we can cover a wide range of knee ailments and a wide range of treatments other than surgery. So let's start with kind of some basic knee anatomy. So the knee is composed of three bones: the femur, which is the thigh bone, the tibia, which is the shin bone, and the patella, which is the kneecap. This kneecap was flipped out of the way to show you. This person's in big trouble. And the other structures that we talk about when we explore the ideas of health of the knee are the soft tissue structures, the things that don't show up on X-ray but maybe will show up on an MRI, which are the cartilage rings called the menisci, the ligaments in your knee, including these two deep ligaments and the ligaments on the side here, and the cartilage covering of the bones called the articular surface, like the white stuff on the end of the ticker bones. So now you know what the knee looks like. And you have to realize that along with this, the knee is bathed in fluid. Everybody makes a little bit of joint fluid to lubricate the tissues, and there's a whole lot of molecular interactions that are going on at the same time while you're moving the knee, which is not only a static thing, but a dynamic thing. And while the structures are moving, the joint fluid is not only lubricating the surfaces, but nourishing the surfaces through a lot of molecular interactions. And that's part of a lot of disease in the joint these days. And some of the treatments are aimed toward the molecular level of what happens to these things in your joint fluid when you're suffering from knee problems. There will not be a test. Okay, so most people when they complain of knee problems are talking about stiffness. And that could either mean stiffness that the joint is just becoming less mobile, or that it gets stiff when you're sitting still or immobile for a while. That they have pain when they move, that the knee swells, which is a sure sign something is going on inside your knee, or that they feel a sense of popping. And these are some treatable joint diseases that we're really not going to talk about today, but these can also cause knee problems, and those are gout, also known in the olden days as the disease of the rich, because it comes from a diet that's high in protein like meat and beer and wine, along with some genetic predisposition to not be able to get rid of certain amino acids which then crystallize in your knee joint. Rheumatoid arthritis, which is an autoimmune disease where your own antibodies are attacking the lining of your knee joint that make knee fluid. Psoriatic arthritis, which is another autoimmune disease. And there's a whole host of inflammatory autoimmune diseases that we're not going to touch upon that can be treated with medicines and usually a visit to a rheumatologist. So let's talk about anterior knee pain. This is a very common kind of pain, and it's anterior means the front of the knee, and this is knee pain that comes from the front of the knee. And one of the more common things is called prepatellar bursitis. And you can see this person here has this giant swelling on the front part of their knee, and that is common in people who do a lot of kneeling, like carpet layers, or people who install floors for a living. And what it is an inflammation of the bursal sac, which is in front of the kneecap, and typically it comes from either irritation or actually getting a small particle like a splinter or something in there where it gets real inflamed. And this is painful, causes swelling on the front part of their knee, And sometimes it can get infected, and then that's a bit of a problem because then you have to do something about it. But if you have a swollen, painful front of the knee from prepatellar bursitis, then most of the time it'll go away with some anti-inflammatories and avoiding kneeling on your knee or just draining it, or in rare cases we have to drain it and actually take the bursal sac out. The good news about this is it's not really a knee joint issue. It's really the tissue right in front of your kneecap underneath your skin here. So you can have a totally normal knee joint, but have a really awful case of prepatellar bursitis, which causes pain and swelling in the front part of the knee. So when we talk about anterior knee pain that is stemming from the knee joint itself, we talk about a dull ache that seems to be coming from the kneecap, deep in the kneecap, the front part of the knee, and it's usually worse after sitting or using stairs because you put a lot of load through the kneecap when you're using stairs and you're going up and down on one leg and you're putting about 7 times your body weight through that joint. And it can be caused by cartilage issues like arthritis, that is the wearing away of the cartilage surface on the back part of your kneecap, or the groove in the end of the thigh bone where it glides. Or it can be caused by malalignment issues, which is a poorly tracking kneecap in the groove on the end of the thigh bone. And as I said, arthritis can be either the wear and tear kind of arthritis like we're all used to, or some inflammatory arthritis like those other diseases I talked about earlier. And we'll get to those in a minute. The other thing that causes knee pain is a strict mechanical issue, and that is something that is blocking motion in the knee joint, coming from an anatomic problem. And here is a torn meniscus, which is a common kind of occurrence in the Middle Ages, and that's because the menisci, which if you look are these 2 cartilage rings that sit on the top of the shin bone where your the knuckles from the thigh bone rest, and if you were to look down on your shin bone it looks like this. And there are fibers in these menisci that not only go circumferentially like this, but radiate out this way. And as we get older, those fibers start to break down. And when you squat or twist or have a sudden kind of loading, shearing kind of event on these cartilage rings that are breaking down, they can tear. And so what happens is you end up with a painful swollen knee. It hurts either on one side or the other, depending on which meniscus is torn. And you go to the doctor, and the doctor says, you need an x-ray. And we get an x-ray, and because it's made out of cartilage and not bone, it doesn't show up on the x-ray. So then your doctor says you need an MRI. And here's an MRI of a knee. And if you look at this, this is a side view of the knee. Here's the thigh bone, the shin bone, and the kneecap would be up here. And this is the back part of the meniscus. This is the front part of the meniscus. So it's this cartilage ring you're looking at like this, being sliced by the MRI machine. The back part and the front part should look like black triangles. And you can see in my years of training, I have been educated to identify the white line and the black triangle. And this is a torn meniscus. So when a patient has a torn meniscus, I say the best way to take care of this is to do a knee arthroscopy. And that's a procedure where I make 2 little poke holes, put a scope in one hole and a tool in another hole, and when I look in there and look at that meniscus, it looks torn like this. This is an abnormal meniscus. It should look like one solid ring, and this is a tear where this meniscus is torn and flapped over, and so what I would do is just snip that off, and we'd be done. So that is a meniscal tear. Now, can you treat a meniscal tear without surgery? If you do, you risk this tear, or this tear, it's better to look at, rubbing on the surface of your knee joint, the articular surface, which is normally smooth and like glass, and eventually wearing this down, causing arthritis. So a good way to treat this is to get it out of there. If you already have arthritis in your knee, then sometimes I'd offer you a cortisone shot. And a cortisone shot is a good way to decrease swelling in the knee, and it's a good way to decrease pain. It will help with the arthritis symptoms. It will not help with this mechanical problem of a torn meniscus stuck in your knee joint. So, if you just have a torn meniscus, it's a surgical problem. If you have arthritis, knee arthroscopy is really not the cure for arthritis. So, that's the story with meniscus tears. Sometimes you end up with a loose body in your knee. And a loose body, as you can see on this x-ray, is a piece of bone that's floating around in your knee joint like a rock in the gearbox. And when you have a rock in the gearbox, you complain of pain and swelling in your knee, but you also complain that every once in a while it gets stuck and you can't move it. You got to move it around a little, and the loose body comes out of the joint surfaces, and then you can move it again. So most of the time, a loose body will be floating around on the front part of the knee, and it looks like this. Sometimes people have bad arthritis, and they have these loose bodies, and they're stuck in the back ligaments of the knee, and this usually isn't that much of a problem. And when you go in with a scope to fish this out, sometimes it looks like this. This is the surface of the thigh bone, top of the shin bone. This is a normal-looking meniscus without a tear in it. And that's a piece of bone just sitting in there. And when you take it out, it looks like that. That's got to feel better. Another cause of anterior knee pain is patellar instability. And that means your kneecap, which sits right here, is wobbling in the groove on the end of the thigh bone. And if you looked head on at your bone, some people actually, in extreme cases, dislocate their kneecap off to one side. And that will result in a tearing of the medial patellofemoral ligament. Almost always it goes off laterally. So you tear the ligament on the medial side, the inner side of your knee. And that hurts. And that's not really the most common version of patellar instability. The most common version is that your knee is just wobbly in this groove. And that hurts too. Especially when you're doing things where you're putting a lot of load in there and you can't, with your own muscles, center your kneecap correctly in the groove on the end of your thigh bone. And we'll talk a little bit about that later on, what you do about it. Sometimes you have knee instability, that is instability between the thigh bone and the shin bone and not the kneecap. And that can be caused by rupture of either the anterior cruciate ligament, like Tom Brady had, or the posterior cruciate ligament, which a lot of NFL linemen have and play with, or a rupture of the collateral ligaments on the side. And this can cause instability, the cruciate ligaments deep in your knee, in a sense that your knee feels like you can't stabilize and it's giving way back and forth, and a lot of people say it'll feel like it either buckles or it hyperextends. If you have a collateral ligament injury, and those are loose, they say it's unstable on uneven ground in a side-to-side kind of motion. Okay, so when we talk about treatment for these things, and we're not using the stuff I like to play with in the operating room, we say that the treatment has to be problem-focused, effective, efficacious in that it's effective and cost-effective and have very minimal side effects. So what are we talking about? For anterior knee pain, which is pain between the patella, the kneecap, and the thigh bone, we call patellofemoral pain. We talk about flexibility of your quads, retinacular stretching, that's the ligaments that hold the kneecap to the end of the thigh bone, taping, rehab, some alternative medicines or anti-inflammatories. And one of the most effective things you can do as you get older is to stay flexible. Quad stretching is a really important way to keep your kneecap tracking at the end of your thigh bone. And this is how you do a quad stretch. This is a good way of doing a quad stretch. This is a better way of doing a quad stretch. Now, not a lot of us can bend our knee like that anymore. I don't think I started out bending my knee like that. But why this is so much better is that the quad muscle comes up and attaches over the hip joint. So in order to get a good stretch, your hip joint needs to be completely extended. And so this guy's doing it correctly, but most people you'll see will cheat and bring their knee up here because it's not as good of a stretch and it doesn't hurt them so much. So what you need to realize is that in order to get an effective quad stretch, your knee has to be back, your hip needs to be extended. And most people can get, while they're not touching their rear end like this, within about 4 finger breadths of their buttock. If you see that you're getting less flexible, and certainly if it's one side more preferentially than the other, this is the exercise to do. And this is why you need to do it. This is kind of a physics diagram of the loads placed on your kneecap. And you can see that the two things that increase the force vector of the kneecap hitting the thigh bone are the length of this vector and the length of this vector. And those are affected by how mobile and stretched out your quads are. So by decreasing the force coming from your quads, you will decrease the force of your kneecap being pushed into the end of your thigh bone. And that will decrease your pain. Another thing you can do, or have a therapist do, if you're having problems with the patella, the kneecap, gliding in the groove on the end of your thigh bone, is to stretch out the medial or lateral retinacula. And these are ligaments that attach the kneecap to the end of the thigh bone and hopefully stabilize it and center it in the groove on the end of the thigh bone. But sometimes one is preferentially tighter than the other. And you can have a therapist actually manually stretch out these ligaments. Lately, over the last couple of years, you may have seen Olympic athletes with all kinds of tape on them, and that's because taping's become a much more accepted and effective way of dealing with, with flexibility issues. And therapists now are really good at using this stuff called kinesio tape, which help if you're having patellar problems or muscular problems by putting forces in different ways through the soft tissues. And the last thing is arthritis. Most of us throughout life will have some kind of arthritic condition. And most of the time it is a wear and tear kind of condition that results in the cartilage on the end of your bone breaking down. And this is what it looks like. This is a non-gory picture of what actually happens. And it's this white stuff like I said, the end of a chicken bone that we have in our joints that starts to break down for various reasons. It could be trauma. It could be you were born to the wrong parents. It could be that you had previous surgical procedures before, or injuries, or certain medicines that eventually cause the breakdown of that soft tissue. And when that starts breaking down and you expose the underlying bone, that hurts. So what do we do for that? There's basically 3 treatments. You have medicines, you have injections, you have bracing. So when we talk about pills, you're talking about supplements like glucosamine, which is, I think, a fairly effective way of treating mild knee pain from arthritis or inflammation with almost no side effects other than the cost of the medicine. And so what they found with glucosamine and chondroitin, it's got to really be the compound that's both together, is that it has some minimal effect on a moderate amount of patients with pain in their joints. And so what I tell people is, you might as well try it. There's almost no downside other than a change in your GI tract function. And if that's uncomfortable, then you just stop it and you go on to something else. MSM is a sulfur-based supplement that works in a similar way to glucosamine with similar side effect profile and similar clinical outcomes. And then anti-inflammatories, everybody knows, as Motrin or Aleve or ibuprofen or the 100 other ones that are clinically proven to be more effective than the supplements, with a whole host of other side effects that can be problematic, like ulcers in your GI tract, kidney function problems, and heart disease. So they're not benign, but they're pretty good. The next is a needle. This is what people think we're injecting in, like a giant bazooka size thing. It's really not that big, and it's not that painful. And I have had everybody pull through so far after a shot in their knee. But they come in two varieties, and one is a steroid injection. And steroids are just a very powerful anti-inflammatory. No different than the steroids your adrenal glands make, but it's concentrated all, we put it in the knee joint. Steroids come in 100 different packages, but they all pretty much work the same way. And typically we inject the knee joint with steroids and a local anesthetic like lidocaine or Marcaine to give you some relief instantly. And then the second kind of injection is called viscosupplementation. And that's the newer kind of gel lubricant thing that's been out for probably maybe 15 years now. And these have been proven to have a fairly good effect. And I would say about a third of people who have knee arthritis in the mild to moderate range get some excellent benefit with viscosupplementation. There's almost no downside other than you get a shot, and there's... Yes?
Is what you're speaking of now with the injection with Synvisc?
Synvisc, Orthovisc, Hyalgan. There's about a dozen of them now. But Synvisc is probably the most common. And so other than the side effect of some people can get a flare for about a day or two. They can get an inflammatory reaction to this. Or the mild, minuscule chance that you get an infection from the shot itself. There's no downside to this. And it acts as a mild anti-inflammatory and a lubricant. And remember that slide I showed earlier on that had all the molecular interactions in the knee joint fluid. It changes that to be more normal. And it's also that these compounds are electrically charged, and the cartilage that's breaking down on your knee is electrically charged, and they adhere to try and heal that region. So those are the two kinds of shots you can get. I thought that was great. This is a guy whose parents had a great sense of humor. But you could also go to a cane or a walker if you're having problems ambulating. And it's a good way to unload your joint and provide some stability, especially if you're getting older and having balance problems or the weather's bad. Another thing that's been proven to help with balance, joint function, and pain are kind of the Eastern movement stuff like yoga and Tai Chi. And these really have been studied and proven to help older people as your balance starts getting off, or your sensory modalities like your vision and your inner ear start having difficulty, will really help you. So it's kind of a nice thing to get involved with because nobody's poking a hole in you, and it's actually really good for you. No talk about surgery. So that's my spiel about knee pain. What questions do you have? Yes?
Is it possible to stretch your meniscus and not tear it?
Maybe.
And if you do that, can you correct it yourself, or does it have to be? Is it just downhill from there?
Usually, if there are, the meniscus is, if you look at it, it's like a C, and it has 3 zones. The very outer zone that's attached to the capsule of the knee joint. Let me go back to that picture. So if you look at this, the very outer zone here has a rich blood supply. And that part of the meniscus, when it's torn or damaged, can heal. And so I think we see a lot of people over time who can have a meniscus injury. They hurt, but then it heals over time. And that's probably the people who damage the meniscus out here. Most people have some kind of tear in this portion where the blood supply to that structure is poor and it won't ever heal. And so the answer is there probably are cases where menisci heal by themselves, but I think if it's a chronic thing, it's probably not in that region that healing's going to happen. Yes?
I actually had surgery to repair a meniscus tear, and I remember that part of the therapy afterward was they said bike, and do some more biking. So I'm wondering if there are, you mentioned the Tai Chi and the yoga, I wonder if there are sort of activities and maybe even things you might find at a gym, like they do have recumbent bikes and upright bike, if there are things like that that are good for knees.
So knees are like cars, as soon as you start using them, you start wearing out. And so there are things that are better for knees. And the non-impact exercises are lots better for knees. So we call these closed chain exercises, where you're on a bike and both your feet are planted on the pedals or on an elliptical machine where both of your feet are always in contact with that. So, having said that, the benefits of being active, whether or not your knees or your feet are planted on a machine or not, far outweigh the risks of the issues. Yes?
Might you be able to elaborate a little bit on the taping concept? How does it work and what's it do?
So how the taping works is usually it's applied by a therapist. So you get a prescription to the therapist, you go there, and what they will do is direct the forces of the knee with tape so that it's counteracting the problem. So let's go back to this taping part here. So let's say you have a kneecap that is not centered in the groove on the end of your thigh bone, wants to come laterally out this way. What they would do is put a piece of tape around your kneecap this way to help direct the forces the other way. Now sometimes it's not a bone issue, but it's a muscular issue, and they can also deal with the muscles around the joints as well in the same way. And it's just a matter of accentuating the forces that you want to accentuate and counteracting those by putting an external force on it. It's something you wear for a few days and then they may have to change it.
And how do they determine that? In terms of how, what kind of geometry do they come up with in order to be able to accommodate whatever concern they
It
have?
depends on the diagnosis you carry. When you go to the therapist, if I say you're having iliotibial band tightness, they may put something on that's just like this, where it's kind of pulling longitudinally on the skin over the iliotibial band. I mean, it really depends on the diagnosis that you bring into the therapist. So there's different ways of taping for every single thing that you could possibly come in
And
with.
how effective is it?
It depends. If it's really a dynamic issue, then it's pretty effective. I mean, some people, they get taped and they say, I feel better right now. Now, it's not for everything, but if you carry a diagnosis that's amenable to that, I've seen people get taped right in the office and say, I feel better. If it's a shoulder issue where they have to bring the shoulder back because of posture kinds of issues, they do. They get kind of instant relief. But, like I said, it really depends on what diagnosis you're going into. Yes?
Would you talk about orthotics?
Yeah. So, sometimes I try to stay away from feet. I'm not a big foot guy, but sometimes,
Changes the mechanical.
yeah, it does change the mechanics of the knee. If you're flat-footed, or you pronate or supinate, or you have rotational components of your tibias, your shin bones, sometimes they can be corrected with orthotics. Most people, by the time they get to be middle-aged like me, they're already in orthotics, you know, because those are things people usually get in their 30s or even 20s, 30s. So they're kind of wearing those out. So do they have a role? Yeah, but is it going to change your life? I don't know. I haven't seen lots of people where they wear orthotics for knee problems, and they say this is a real change of life. But you know, some people say they get better. It's like bracing. You know, I kind of put up a picture of a brace. Sometimes unloading the knee one way or another helps. You have to have the right knee for the right brace, and you got to wear the brace. It's a difficult sell. I'm not saying you shouldn't try it. I'm just saying it's not always the most effective way to deal with stuff. But it's important concept to correct if you're having problems.
Thank you.
Yeah.
What about heat? Or like elastic stockings? Or elastic
Yeah.
brace?
Yeah. So sometimes that compression can help you. People feel better just having that little bit of support. I cannot tell you the science behind that. But if it feels all right and it's not hurting anything, I say try it. In terms of heat, you know, heat makes you dilate your blood vessels and increases blood flow to the area. And sometimes that does help people. Sometimes people are already having too much blood flow from inflammation. You want to decrease that with ice. And so it really depends where you are. Sometimes in an acute kind of injury, or if people say, you know, I walked a mile in the mall, I paid for it for 2 days. I would say after you're walking in the mall, get ice on that knee. Yes?
Is there any way to slow down arthritis? Or are we always treating it after that?
That's a great question. And, you know, we're talking about wear and tear arthritis, because there's ways to slow down the inflammatory arthritis stuff, like I talked about the rheumatologic disease with medicines. But when you're talking about wear and tear arthritis, the ways to slow it down are to unload your joints. So I like for people to stay active because it's better for you and you live longer when you're active. but you have to be the right kind of active. You know, I would say if you're a runner, you need to stop running because your arthritis is going to get exponentially worse from the pounding on the knees. Now, you know, there are some people that can't give up that kind of stuff, and certainly, you know, being in good cardiovascular health is worthwhile. So if you can't, you can't. But I say if you can, modify your activity so you're not putting loads like that on your joints. So if you're somebody that's known to have arthritis, that's prone toward treatment, I would say don't run up and down the steps at work every day. You know, use the elevator and just modify your activity level. Unfortunately, I mean, you know, there are claims that some of the supplements will help slow down arthritis. I don't know that there's any science behind that. Yes?
What about swimming?
I think you should do it. I think it's a great exercise, and it unloads everything. And you know, as long as you're not susceptible to drowning, you should do it.
Would you repeat that? There's some people who didn't hear what she had asked.
What about swimming? And swimming's a great exercise because it unloads all of your joints, makes you buoyant. Even running in the water, you know, you're not loading your joints, and that can give you a cardiac workout. And so that's a great exercise too. Yes?
So once you have damage to the cartilage due to trauma or a severe injury, is that cartilage going to come back at any rate, or once it's gone, it's gone?
Once it's gone, it's gone. But here's the good news. If it is trauma where you have, let's say, just an isolated lesion that's less than about an inch in diameter, there's ways to get that to heal. Not non-surgically, sorry. That's not for this talk. But if it's global kind of trauma to the joint, that's kind of beyond the scope of those procedures. So some traumatic cartilage defects are able to be cured with certain kinds of either arthroscopic procedures or transplanting cartilage like a hair plug, you know. Sometimes we can take a plug of cartilage here and put it in here. Or in extreme cases, an allograft where we get a piece of cartilage and underlying bone from a cadaver and put it into a defect. More commonly, though, as we get into middle age, it's just more reliable to have partial knee replacement. Yes?
Yeah, genetically, I have a history of arthritis in my parents. And I'm wondering, right now I just have kind of one sore knee. If I have arthritis, would it locate in both knees or just one knee? Does it make a
Sometimes
difference?
it's one. I can't tell you why some people have multiple joints that are arthritic and some people have one. But I see people in both groups all the time. Yes?
What are bone spurs?
Bone spurs are, here they are, right here. Bone spurs. They are an interesting artifact from losing the cushioning of the cartilage in your bones. And what happens is when your body senses that the bones aren't being cushioned enough, it tries to make more bone to spread the load out across the joint. It's a physics issue, and it's not very effective. But the bone spur isn't the problem most of the time. It's the cartilage that's wearing away, causing you to make a bone spur. That's the problem.
That occurred, I believe, with my son when he was like 14, in his early teens. Is that
A little bit different. Well, a little bit different. When kids, you're talking about in the knee?
Yeah.
So sometimes kids, when they're developing, especially teenage boys, in the teens, when they're jumping up and down, and they're putting a lot of tension on, usually it's around the kneecap, they'll get a big bone spur on one side or the other, or even the tibial tubercle where the ligament attaches to from the kneecap to the tibia. They'll get a big bone spur there. And that's more of a traction bone spur, a little bit different.
Does that have future effect on?
It shouldn't. It shouldn't. Yes?
How effective might acupuncture be?
Acupuncture has been shown to have some moderate but temporary relief for joint pains. And they've studied it, and it's really kind of reliable scientific research that shows it might be worthwhile to try it. I mean, there's a reason why Eastern medicine's been around for thousands of years. I don't know a whole lot about it, but there is some research that shows that you can get some short-term relief, although it's not really modifying the disease at all. Way back there.
Improper body alignment have anything to do with the development of the arthritis and the wearing of the cartilage?
Yeah, I mean, if you're talking about things like spinal curvature or pelvic obliquity, things like that, anything that will cause kind of an uneven distribution of weight can. Limb length discrepancies can do that. And so, it's really a load issue on the particular cartilage parts. Yes?
My mother was diagnosed that she had calcium deposits on her knee,
Yeah.
and so it made her one leg longer than the other. Is there something that can be done for that?
I'm a little unsure about what you mean by calcium deposits in the knee, but the calcium deposits that I see most commonly are calcium deposited in the meniscus, and that is called pseudogout. That doesn't really change your leg length. It just means that your meniscus rings are becoming hard, like hardening of the arteries is hardening of the meniscus, and it ends up giving you arthritis.
And her knee was really swollen, twice the size of the other one.
And so if she had a calcification in the knee, remember that picture I showed on loose bodies? Most of the time it looks like this. But that doesn't really change the length of your limb, other than sometimes it can cause a joint to be contracted from the soft tissue irritation, but it won't really change your leg length.
It just seemed like it was. She's gone now.
Not from that.
No, I don't know what from.
Right.
You always, they always tell me to put ice. If you put heat, I put heat on the patient because it feels good. And it kind of numbs it, really feels good. Does it do any harm?
No, it doesn't do any harm. There are knee wraps now where you can either heat them or cool them, and there's actually ones that have hot or cold water going through them at times, and it's really a subjective kind of thing. If it feels better, then keep doing it. You're not doing any harm. Yes?
How many steroid shots can you get within a period of time, like every 10 months or a year?
Yeah,
And
so
if it doesn't work anymore, then you have to see about surgery? Is that the last resort?
okay, so there's a couple of parts to that question. First is how many steroid shots can you get? Maximum steroid in your knee is fairly dose dependent, but what I say with what I use, no more than 3 a year. 3 shots in a calendar year. And you can have that if they're working forever. But most people find that they work for a shorter and shorter period of time every time they get an injection. So when they stop working, what do? you either switch to a different injection, or you say, can I live with this pain or not? Doesn't mean you need surgery. It's a pain issue, and really it comes down to whether or not you're willing to live with that kind of knee pain.
Thank you.
Yes?
On these shots, I was told that that the orthoped doesn't do it because they're done, is it robotic type or something with a screen that you go,
So I do them.
oh, you do?
I do, but there's also some people who do them under ultrasound. There is a small percentage of the time where I can put the needle in the knee joint, I think, but it's not actually in the knee joint. With ultrasound, there's less of a chance of that happening. The chances are small that that happens. So with knees, it's a big joint. It's hard to miss. It's a little different than, you know, putting in one of your wrist joints or things like that. So I've never really resorted to the ultrasound thing because it tends to just beef up the cost of the shot.
And another question was, by doing some of the exercises and when they really, really hurt, I think it was Cleveland Clinic, they said it doesn't hurt. I mean, as long as you can stand the pain, do it because it's not going to damage you. So
Well, you know, I'm a believer that if you're having pain, that's some signal that your body's saying stop this. Because my motto is no pain, no pain. I want to have pain. So, you know, if you want to, there's lots of different exercises you can do that are more comfortable than others. I think if it's hurting you, you should be doing it. Now, does that mean that you're actually damaging your knee joint? If you've already have an arthritic knee joint, probably not. But there's lots of other exercises that you can do, I think, comfortably without having knee pain. That'll give you some benefit. Well, thank you. If there's no other questions, thank you all for coming. I appreciate your time. Hope you learned something. Yes, one last one.
All right. On the injections, do you have a preference over steroids over the visco supplements?
Yeah, I try the steroids first, and the only reason I try them first is because many more people get relief with steroids, and they're lots less expensive. And the problem with the steroids is I have no idea how long they're going to last. Some people say I got a day's worth of relief. Some people say I have a year's worth of relief. So that's really where the uncertainty comes in. With the visco supplementation, like I said, about a third of people say it helped. 2/3 of people say it's not really. And they cost a lot of money. So
Well, I've already had 2 of the myalgia series, and I've had relief on both so far. But
so I would say
it hasn't
stick
been
with
for
it.
6 months then.
What's that?
My doctor that has given it to me has said we can't give you another series of shots for 6 months.
Right.
Now you're saying steroids I can have a little bit sooner.
Correct. And you can even kind of alternate.
And I'm also trying to forestall the knife.
I hear you. Yes?
You know, in the effort to forestall the knife and you're trying the injections, are you doing further damage to your knee? And does that mean if and when you go with the knee replacement or a partial knee replacement, you've actually, it's going to be a more serious operation?
And the answer to that is probably it's going to be a little more work surgically later on, but not out of the realm of what you need to do to replace the knee. So I would say put it off for as long as you can, as long as you're comfortable with the non-operative treatments. I think I said that in the office. Isn't that what I said?
Yes. Just checking.
Did I pass?
That's a second opinion.
At least you didn't tell me I was ugly, too. Well, thank you, everybody. And come to the next talk.